Hello, I'm Ed Bell from the University of Iowa. I'm honored to be here as a speaker in this wonderful city, and it's been my pleasure to reconnect with some old friends, and I'm looking forward to making some new friends in the next few days. I want to thank Professor New for inviting me to be on the program for this conference, and I also want to reiterate what was said earlier about Professor Georg Zimbrunner, who had the vision and foresight to initiate this series of conferences now more than 25 years ago. And I think it's been a very successful effort, and I hope it will continue. And as I said, I'm glad to be here participating. My first topic today is the micronutrient requirements for low birth weight infants. Before we begin, here's a picture of my hospital in the University of Iowa. Everything you see in the foreground here is parts of the hospital. The old original hospital was here, built in 1928. Here you see the football stadium. The city of Iowa City has about 60,000 people, so it's a very small city. And the football stadium holds 70,000. And it's always filled. Here's the Iowa River. It divides the city in half, and over here is the business district and the rest of the university, but the medical campus is all right here. What are micronutrients? The micronutrients are essential elements that are needed by the body in small quantities. They've been called the magic wands of nutritional health. They enable the body to produce enzymes, hormones, and other substances that are essential for proper growth and development. As tiny as the amounts are that we need, however, the consequences of their absence can be severe. There are two main groups of micronutrients, the microminerals or trace elements, which are iron, zinc, copper, manganese, selenium, chromium, molybdenum, and iodine, and then the vitamins, which are divided into two groups, the fat-soluble vitamins and the water-soluble vitamins. There's some other nutrients that we might also consider that are necessary in small amounts in the body. Let's start with iron. Iron has some very important functions in the body. The first is oxygen transport and storage by heme-containing molecules such as hemoglobin and myoglobin. We've already heard this morning about the importance of oxygen in fetal and neonatal nutrition, but without iron, we're limited in the oxygen that we can deliver to the tissues. Iron also has a role to play in electron transport and energy metabolism through the cytochromes and NADPH dehydrogenase. It has an important role in some of the enzymes that are important for antioxidant protection, such as catalase and peroxidases. It's necessary for the function of prolyl hydroxylase, which is essential for the response to hypoxia, and it's involved in DNA synthesis through the enzyme ribonucleotide reductase. Iron is the third most abundant element in the Earth's upper crust by mass, after silicon and aluminum. Now, most of the iron in the newborn accumulates in the third trimester of pregnancy. And so if the baby is born prematurely, the iron stores are quite low. The most common manifestation of iron deficiency is iron deficiency anemia. In the preterm infant, iron deficiency can also cause impaired neurocognitive function, which can result from low iron stores at birth and low dietary iron intake. The iron requirement, if given enterally, is 2 to 4 milligrams per kilogram per day, and we may actually have a higher requirement if phlebotomy losses are high or if erythropoietin therapy is being used. If it's given parenterally, the requirement is much smaller. Well, the most common sources of iron in the neonatal diet are from milk or preterm formula, but neither of these completely meets the needs for iron. If you look at the amount of iron that's provided from unfortified human milk, the amount that's retained is quite low compared to the fetal accretion during the equivalent time in gestation. Iron-fortified preterm formula is much better in terms of the amount of iron, but still falls short of what the fetus is accumulating during development. So we have to provide some additional source of iron besides what we get from the human milk, at least. As I said, human milk doesn't contain enough iron, and the required iron can be provided by iron-containing fortifier or ferrous sulfate drops. And these can be started early once the baby gets close to full enteral intake, even though the erythropoietic rate is usually low in the preterm infant for other reasons besides iron deficiency. For infants who don't have human milk, we routinely use iron-fortified formulas, and the fortification level in the United States is about 12 to 15 milligrams per liter, depending on the concentration of the formula. There are other sources of iron for the neonate. The initial transfusion that the baby receives from the placenta at birth provides lots of iron in the form of red cell hemoglobin. Postnatal transfusions provide additional iron the same way. And then the natural destruction of red cells that occurs in the body provides another source of iron, as this iron can be recycled, whether it's the red cells are destroyed by natural aging or by abnormal hemolysis. There are some concerns, at least theoretically, related to iron excess in the preterm babies. In the 1970s, there were some reports of increased hemolysis in babies who were receiving large amounts of iron in their formulas. There were some experimental formulas at that time that contained much higher amounts of iron than what we use now. And in addition, formulas in that period had low vitamin E and high levels of polyunsaturated fatty acids. So these other aspects of the formula composition were ideal for producing hemolysis. This is not a concern with human milk or modern formulas unless the iron intake is very high. However, iron is a pro-oxidant, and it helps to trigger generation of reactive oxygen species. And as we know, the preterm infant has immature antioxidant systems. So while iron is very important and it's essential, we also have to keep in mind that we can cause harm by providing too much. This is true of almost all nutrients. We need enough, but not too much. Now let's turn to zinc. We all need zinc. The functions of zinc are, first, its catalytic function. There are many enzymes that depend on zinc for their ability to catalyze vital chemical reactions. Zinc is an important element of the structure of certain proteins. This is called zinc fingers, and it's an essential component of cell membranes. Zinc has some regulatory functions. These zinc finger proteins regulate gene expression by acting as transcription factors. And zinc is also important in cell signaling and apoptosis. I don't expect any of us will remember all these functions of each micronutrient, but just to impress on you that there are many functions of most of these elements, and that they're very important. 60% of the fetal zinc accretion occurs in the third trimester, much as with iron, and it accumulates mostly in the liver. Preterm infants are at risk for zinc deficiency, especially during periods of rapid growth. The intestinal absorption of zinc is about 25 to 40% of what is fed in the diet, and so significant losses occur in the stool, but also in the urine of preterm infants. Deficiency can occur with zinc-free parenteral nutrition and breast milk feeding with low zinc levels. Zinc deficiency causes a skin rash, which is commonly misdiagnosed as candidiasis or eczema. It causes poor growth, diarrhea, and irritability. And in some patients, it can cause acrodermatitis enteropathica, which is an autosomal recessive deficiency in zinc absorption. Next is copper. Copper is an important component of coenzymes called cuproenzymes. It participates in free radical scavenging. It is important in cellular energy production through the cytochrome C oxidase. It's involved in cross-linking of collagen and elastin through the enzyme lysyl oxidase. And the oxidation of ferrous iron to ferric is important in ceruloplasmin and for oxidase 2. And lastly, copper has an important role in several antioxidant enzymes, most significantly certain of the superoxide dismutase enzymes, but also ceruloplasmin. There are some important functions of copper-containing enzymes in neurological function, in particular neurotransmitter synthesis, neurotransmitter metabolism, and myelin formation. Each of these functions depends on an enzyme that either contains or is facilitated by copper. Melanin formation also depends on copper, and regulation of gene expression, in particular the genes for copper zinc superoxide dismutase, catalase, and copper storage proteins. Copper deficiency in the preterm infant. Once again, copper is mostly stored in the third trimester, mainly in the liver. Deficiency of copper in preterm infants is very rare because breast milk and formula provide adequate intake. If you had a baby that had prolonged total parenteral nutrition without any source of copper, you could see copper deficiency. The deficiency presents as hypochromic anemia, which is unresponsive to iron, neutropenia, and osteoporosis. It can also cause pallor, decreased pigmentation of the skin and hair, skin exanthem, poor growth, diarrhea, and hepatomegaly. You should not give copper supplementation in babies with cholestasis because the copper is not metabolized normally in those babies. Next is manganese. Manganese is a component or activator of multiple enzymes. It plays a role in antioxidant protection in the mitochondria through manganese superoxide dismutase. It has an important role in some of the enzymes of gluconeogenesis and one of the urea cycle enzymes, and it's involved in glutamine synthetase, which regulates conversion of glutamate to glutamine. I should have asked earlier, but do you have available trace element mixtures that contain these elements for your TPN? Okay. Selenium is essential for the selenium-containing enzymes or selenoproteins. The glutathione peroxidases contain selenium, and these are important in antioxidant production. Selenium is involved in the conversion of thyroxine to triiodothyronine, and there are other important proteins that contain selenium, and those are listed. Chromium enhances the effects of insulin. The mechanism's not very well understood, but it does seem to be essential in very small amounts. Molybdenum is also essential in very small amounts. Molybdenum cofactor, in particular, is essential for certain enzymes which are listed here. Iodine is an important component of thyroid hormones. So iodine deficiency is common in later life, but not in preterm infants. Worldwide, however, 30% of children are estimated to have inadequate iodine intake. And so iodine supplementation through table salt or other means is very important. Preterm infants in areas of low endemic iodine intake do require higher intake of 40 to 60 micrograms per kilogram per day. An interesting fact related to iodine is that generous use of iodine-containing antiseptic solutions may cause the baby to become hypothyroid by down-regulating thyroid hormone production. Here are the recommended daily intakes of trace elements. You can see there are two columns, one for the enteral intake and one for parenteral intake. For some, these are essentially the same, but for other nutrients, there's quite a difference between the enteral and parenteral recommendations. These are taken from a textbook edited by Reginald Sang and others called Nutrition of the Preterm Infant. I think it's one of the best sources for these estimated requirements. In most cases, these are not precisely determined by experimentation, but are based on the best guesses of experts. Now we'll turn to the vitamins. First, we'll talk about the fat-soluble vitamins. Now, as Professor Hayes showed you earlier this morning, most of the newborn infant's body fat accumulates during the third trimester, and the preterm infant has low body fat stores and consequently also low stores of fat-soluble vitamins. Thus, preterm infants are at birth, at least in some sense, deficient in vitamins A, D, E, and K. But remember, too, that these vitamins are potentially toxic if we give too much. Vitamin A is really a group of related compounds that are shown here structurally: retinol, retinaldehyde, retinoic acid, and retinol esters. One of the most important functions for vitamin A is in promoting normal vision, and you can see here the mechanisms of photoreception in the rod cells of the retina. There are various of these retinol compounds involved in various stages, both in the retinal pigment epithelium and within the rod cells. Vitamin A also plays a role in gene expression. Isomers of retinoic acid act as hormones to affect gene expression and thereby influence numerous physiological processes. And through the stimulation and inhibition of transcription of specific genes, retinoic acid plays a major role in cell differentiation. This may actually be the basis for the teratogenic effects of retinoic acid. Vitamin A has a role in immunity. It plays an essential role in maintaining integrity of skin and mucosal barrier function, and also facilitates white blood cell differentiation. It's important in growth and development, particularly embryonic development. So you need some vitamin A for normal development of the limbs, heart, eyes, and ears, but in excess it's teratogenic, and vitamin A regulates expression of the genes for growth hormone. If we don't have enough vitamin A, the first thing that we might see is ocular abnormalities, in particular night blindness, xerophthalmia, keratomalacia. Also loss of appetite, hyperkeratosis, increased susceptibility to infection, and this has been seen particularly with measles outbreaks in Africa and Asia. And it's also, you can also see metaplasia and keratinization of epithelial cells, including respiratory epithelium. As you can see from the countries in red, vitamin A deficiency is a very common problem worldwide. Well, what about vitamin A in the preterm infant? The estimated requirement is 700 to 1,500 international units per kilogram per day. Colostrum and infant formula provide sufficient vitamin A. After the initial colostrum, however, the vitamin A content of human milk is variable, so supplementation is recommended for breastfed babies. Roughly half of the vitamin A given in parenteral nutrition solutions is lost by adherence to tubing or by photooxidation. So you can partially prevent this by using amber bags and tubing, or by wrapping the bag and tube in some opaque substance such as aluminum foil. Most of us don't bother to do this. We know that probably there's going to be enough vitamin A even after the photooxidation. Here you can see the amount of vitamin A that the neonate typically receives. There's a nice concentration of vitamin A in colostrum, and pretty good amount in infant formulas in the US, and I think in Europe. Human milk, however, is low and is variable. If we give 150 ml per kilogram per day, you can see that the intake from human milk doesn't match the recommended intake, but the amount from formula generally does. One important aspect of vitamin A in the preterm infant is that vitamin A supplementation can help to reduce the risk of bronchopulmonary dysplasia. This was an important study published in 1999, done by the NICHD Neonatal Research Network. There were 807 infants under 1,000 grams, and they were randomized to get vitamin A 5,000 units 3 times a week or a placebo. And the vitamin A infants had a lower risk of bronchopulmonary dysplasia or death. It's not a huge difference, but it was statistically significant in this large study, and the risk was reduced from 62% to 55% by vitamin A supplementation. Here is the summary of the Cochrane review on vitamin A supplementation in bronchopulmonary dysplasia. You can see that the risk difference was minus 0.7, and the 95% confidence interval does not include the number 1, so this is statistically significant. One concern that's been raised is that vitamin A is not well absorbed or not predictably absorbed from the gastrointestinal tract. So in order to be sure that you're giving the appropriate amount and it's available, bioavailable, it's given by intramuscular injection. And so some people have hesitated to use vitamin A for this reason. I can tell you that our nurses had concerns about this, but in fact, once we started to give the vitamin A, the concerns quickly went away. It's given with a very tiny needle, the smallest needle that's available, and the babies don't seem to notice it very much. Vitamin D is essential for normal calcium metabolism. It inhibits cell proliferation and stimulates differentiation. It's an immune system modulator. It's required for normal islet cell function in the pancreas, and it prevents inappropriate activation of renin angiotensin system, thus reducing the risk of hypertension. Here you can see the vitamin D. Most of the vitamin D is synthesized in the skin, but of course preterm babies are not exposed to sunlight, so they depend on either their diet or from supplementation. Preterm infants have lower blood levels of vitamin D than their mothers, and they have low body stores of vitamin D. Since they're not exposed to sunlight, they rely on dietary intake. Preterms can absorb vitamin D well and can increase hydroxylation to 1,25-dihydroxyvitamin D in response to hypocalcemia. So that's the good news. Human milk is low in vitamin D. The recommended vitamin D intake is 50 to 400 international units per kilogram per day if it's given enterally. If it's given parenterally, a lower amount is thought to be more appropriate. Infant formula provides adequate vitamin D. For human milk-fed infants, fortifier may provide enough vitamin D. Otherwise, an enteral supplement of vitamin drops may be necessary. And for parenterally fed infants, a pediatric multivitamin solution will provide enough vitamin D. Vitamin E is actually a family of 8 compounds, 4 tocopherols and 4 tocotrienols. It has some important functions for the body. It is actually the most important natural antioxidant in the body. It affects cell signaling. It's involved in immune function and inflammation. It inhibits platelet aggregation, which is mostly a good thing in adults, maybe not always a good thing in preemies, and it enhances vasodilation. Vitamin E deficiency was reported in infants in the 1960s when they were fed these formulas that contained very high levels of polyunsaturated fatty acids and very low levels of vitamin E. But nowadays, vitamin E deficiency is rare. It's usually prevented by routine dietary sources such as milk, formula, and intravenous multivitamins. Vitamin E deficiency, when it was seen in the 1960s, presented with hemolytic anemia, edema, and thrombocytosis. And vitamin E deficiency in infants is exacerbated by high dietary polyunsaturated fatty acid and iron intakes. And the deficiency can be completely eliminated by enteral administration of 5 to 25 international units per day. Once again, the preterm baby has low body stores at birth because most of the vitamin E is stored along with adipose tissue during the 3rd trimester. The serum level of tocopherol rises gradually over the first week or 2 with usual nutrition. Colostrum contains high levels of vitamin E. And an important fact in preterm infants is that vitamin E supplementation reduces the risk of intracranial hemorrhage in preterm infants. This shows the low levels of vitamin E at birth, both in term and preterm infants. The dotted line here shows the threshold of biological sufficiency. And the term infant, the level rises over the first week to normal. The preterm infant, at least with nutrition that was common in the 1980s, stayed low. What we would like to see for the preterm infant is to get the level up faster, so that within a day or so of birth, we have adequate vitamin E level. Here you can see, again, this is weeks of life, so that with nutritional practices of the 1980s, it took actually nearly 6 weeks for the vitamin E level to reach normal. So we do need to make sure that we're giving enough vitamin E. I have to say that this was with the type of nutritional practices that Professor News said we should avoid. This is with starting feedings after the first week, advancing them slowly, and using nutritional sources that don't have enough vitamin E. This is the one of the figures from the Cochrane review of vitamin E versus placebo for intracranial hemorrhage, and you can see here the overall analysis is that there is a reduction of the risk with a risk ratio of 0.85, which means the risk is reduced by about 15%. This is a group of studies with different doses of vitamin E, different routes of administration, different frequency. But if you look at all of these together, it does seem to support a protective role for vitamin E against intraventricular hemorrhage. The recommended intake is 6 to 12 international units per kilogram per day. Colostrum is a great source of vitamin E, so all of our preterm babies, if the mother's willing, will give colostrum as soon as it's available, which is usually in the first 24 hours. And human milk, even after the colostrum, is probably adequate without supplementation, and formula contains enough vitamin E. If babies are not getting fed and they're given total parenteral nutrition, the recommended intake is 2.8 international units per kilogram per day. This is provided by 2 ml per kilogram of MVI pediatric, for example, and you may use a different pediatric multivitamin preparation for your TPN, but whatever you use, it's important to know that the vitamin E that's in there is potentially toxic if you give too much, and the dose is much lower. It's about 1/10 the dose that we would give to enteral supplementation. One reason is that the form of vitamin E that's commonly used in the parenteral multivitamins is the tocopherol acetate, and the enzyme that splits off the acetate moiety is found in the gut. So it doesn't really make sense to give this form directly into the circulation, but at least in the U.S. that's the form that we have, and so that's what we use. Vitamin K, the most important function is in clotting, promoting blood coagulation. It's a cofactor for the enzyme that catalyzes the conversion of glutamic acid to gamma-carboxyglutamic acid in 7 proteins called the clotting factors involved in the coagulation cascade, making it possible for these proteins to bind calcium. Vitamin K also has an important role in bone mineralization. 3 of the proteins involved in bone mineralization are vitamin K dependent: osteocalcin, matrix GLA protein, and protein S. And there are some cellular functions of vitamin K dependent proteins that are involved in particularly this Gas6 protein It's involved in cell adhesion, proliferation, and protection against apoptosis. Well, all infants are deficient in vitamin K at birth, and preterm infants, as term infants, must be given vitamin K at birth to prevent hemorrhagic disease of the newborn. After the initial dose, daily intake of 8 to 10 micrograms per kilogram per day can be obtained from milk or formula. If the patient is NPO, parenteral nutrition should also provide 10 micrograms per kilogram per day. Here's a list of the water-soluble vitamins and what their most important functions are. And we won't go into these in any detail, but they all are essential for healthy survival. Unlike the fat-soluble vitamins, you don't have to be quite so exact in the amount that you give, because excess water-soluble vitamins are just excreted in the urine. Here's the recommended daily intakes by the enteral route and by the parenteral route. And this is taken from the same source, the textbook of Tseng. The recommended doses of water-soluble vitamins that I just showed you are imprecise, and specific deficiencies and toxicities for most of these have not been described in preterm infants. As I said, toxicity is unlikely because the kidneys excrete excess water-soluble vitamins. Preterm infants may be at risk of deficiencies if these aren't given, because water-soluble vitamins, unlike fat-soluble vitamins, are not stored in the body. And because of the rapid rate of growth of the preterm infant, they could theoretically develop deficiencies of some of these. Also, parenteral vitamins are at risk of photodegradation. Thank you. Yes.
Thank you very much. How often we should check and see the level in the blood of these vitamins? And do we have to do that?
No.
Not at all?
Never. If you give the right amount, you don't have to worry about checking levels. Professor New.
There seems to be a large controversy over, and this is a little bit out of the immediate neonatal period, but I'd like to ask the audience and you about the introduction of vitamin D and iron in normal, healthy, breastfed babies. And what do people do? Do you introduce iron at wait till 6 months? Do you give it at 4 months? When do you introduce vitamin D in normal term babies? Breastfed babies. Right after birth. 1 year. After 2 weeks. Term healthy babies. So I'm hearing right after birth, 2 weeks, 1 year. Exclusively breastfed. Okay, vitamin D. Okay, so let's do this over again. Vitamin D, when do you start? 2 weeks. Okay, so huge variation. Ed, do you have any thoughts on that?
Well, I must say that at Iowa we have always recommended supplemental iron and vitamin D, and the preparation that's most convenient in the U.S. is a combination of vitamins A, C, D, and iron. And so that's what we use. They don't probably need the vitamin C. The vitamin A, probably they don't need. But in climates like North America, where babies don't get much sunlight in the wintertime, we don't want to rely on solar exposure. Plus, we don't want them to get the potential harmful effects of UV exposure. So we tend to send the babies home from the hospital with the vitamins or with the prescription for them, just because we don't want to rely on the local physician to start them.
In the United States right now, the American Academy of Pediatrics, there seems to be a lot of discrepancy right now between when iron is started in normal term babies. One group, the Committee on Nutrition, is recommending starting iron by 4 months, and then the breastfeeding group is recommending starting at 6 months. So there's actually some real discrepancy there, and what is the right answer? I don't know if we really know the right answer. As far as vitamin D, starting much earlier than that is indicated. But when you look at what happens in terms of most babies, there's been a few studies done looking at what the pediatricians actually prescribe. And in Boston, for example, only 20% of the pediatricians have been prescribing vitamin D, even though it's a recommendation of the Academy of Pediatrics to start very early. So there's a lot of lack of information that's out there. So.
I was just going to say, to follow up with that, which can be just as concerning as in the infant follow-up clinic, we'll send them home with that from the NICU for our preterm infants, and then we see them in follow-up, and the pediatrician's taking them off it. And so we have to re-educate and restart. What do we do about it? It's hard to change that culture and to infiltrate that knowledge. What we've started to do is in our discharge summaries, not just say what the medication is, but actually give a sentence or two of why and quote the AAP recommendation and statement, see if that'll help with adherence and compliance.
There's a
Yeah, no, for the term babies, I actually like Bill's idea there. We let the pediatrician right now do it, but with this evidence, we have a lot of work to do in our own community.
There's a misconception that iron drops or iron in formula contributes to constipation in babies. In an elegant study that was done some years ago at the University of Iowa, where it was a double-blind comparison between iron-containing formula and low-iron formula, there was no difference, and the parents and the doctors couldn't tell which the baby was on, except the only difference was the color of the stool was a little bit different from the iron.
What about vitamin K in exclusively breastfed infants?
There's not much vitamin K in breast milk, as you know. We don't routinely recommend supplementation as long as the baby has gotten 1 milligram at birth. I think we feel that that's going to protect most babies. But with prolonged exclusive breastfeeding, it could be an issue. I don't know. What do you guys do about that?
No additional supplementation of vitamin K outside the, unless there's some kind of bleeding abnormality.
Vitamin K intramuscularly. In Europe, some countries give vitamin K orally. So if we give vitamin K intramuscularly, we don't need to give it again.
If you give it right after birth,
We prefer to give the vitamin K intramuscularly at birth because it's more reliably absorbed and protects the baby. But we sometimes have parents who refuse the intramuscular vitamin K, and then we try to offer oral vitamin K as better than nothing, but we prefer intramuscular.
One more question. Yes, it's one more. I would like to ask you, how do you give iron in babies preterm or TPN for long term? Do you use IV in the parenteral fluids or give separately? Because usually it's not included.
Yes,
How
I
do
know.
you cover the needs?
Yeah, well, first of all, we almost never give total parenteral nutrition as the only dietary source. Almost all of our babies are getting enteral feeding as well. And so I don't like the term TPN because it implies that that's the only food the baby's getting. And that's really the way we provide nutrition only in those very special cases where there's a discontinuity or an obstruction of the gastrointestinal tract, so enteral feeding is not possible. We do not give parenteral iron except in the form of blood transfusions. So if there's a preterm baby who is very ill and has a prolonged period of parenteral nutrition, they're often going to become anemic and need blood, and they're going to get iron that way. I know in Europe, parenteral iron is used more frequently. Do either of you guys use it, or Bill?
Yeah, we'll sometimes use some supplemental iron in the IV solution. I cannot recall right offhand what the exact dosage is.
Do you remember which compound is it? Do you remember? How many of you use intravenous or other parenteral iron? Older children, okay. Yes.
What is your policy when after blood transfusion? Do you discontinue iron or you continue?
We continue. The question was after transfusions, do we stop iron? No, we continue to give the basal amount, which is somewhere around 2 to 4 milligrams per kilogram per day. And most babies, if they're on full enteral feedings, will get that from the formula. If they're breastfed, we use a fortifier that has iron. But if otherwise, we use iron drops. And we think it's probably not necessary to give the iron for some weeks after a transfusion, but it's easier to give it than to stop and remember to restart it. Yes.
After birth, the preterm babies needs all the trace elements or only zinc for 1 or 2 weeks?
Most of the trace elements you're not going to get into problems with toxicity in a week or two, but we have a standard TPN solution that contains that. So we do start them within 24 hours, but I think you're not going to run into difficulty if you don't have trace elements for the first week or two. Yeah.
A baby with parental nutrition associated cholestasis, will you adjust the trace elements mixture online? Because you mentioned that you will stop the use the copper.
Yeah. I honestly don't know if that's done routinely, but it is theoretically a concern. The copper dose should ideally be reduced. We don't have the babies that we see cholestasis in. Usually, they're already being fed by the time we recognize it, and so we're no longer giving them very much in the way of parenteral nutrition.
As far as your question about the trace elements, I think that's an area that we have. It's sort of an orphan in neonatology where people have not looked very closely at the trace elements in our preterm babies and in the surgical babies. And there's some evidence, talking with colleague Judy Ashner from Vanderbilt, they've been looking at manganese levels and finding manganese levels at very high concentrations in some of these babies that get long-term trace elements. And so I think that it's definitely an area that we need to know more about. We may be giving these babies too many trace elements. So your point is well
Yes.
Also, for babies with cholestasis, is it recommended to give more fat-soluble vitamin into the
Yes.
but usually we won't monitor the C1 level. How can we
Babies with cholestasis, we give additional fat-soluble vitamins. We don't routinely monitor the levels, but if they're going to be NPO for a long time and getting these vitamins, then we do try to check the levels, but not very often.
If I have understand well, if you use parenteral nutrition, do you suggest also multivitamins by mouth or not?
No, we don't give multivitamins by mouth if we're giving them parenterally. Once we stop the parenteral nutrition, then we begin supplemental vitamins if necessary. But most babies don't need them because there's enough vitamins in the formula. There's enough vitamins in fortified human milk if your fortifier contains appropriate amounts. So it's rare that we actually need to give enteral vitamin supplements.